present the next presentation, which is tackling triple challenge, juxtapapillary MNV in book Kainagi Harada with subretinal V. Dr. Deependra Singh.
So very good evening and thanks MUM for inviting me and giving me the opportunity. Dr. Avadallah, thank you so much. I am not a uvea specialist, so spare me if I show something which is not compatible with uvea guidelines. But I think one of colleague he requested that can you bring something interesting. So I thought let me share this a very different case. So young male, he came to us with blurred vision in one eye, left eye for past 3 months, and he has been diagnosed uveitis elsewhere. Basic investigations also done, and when he came to us, he had posterior synechiae and very early posterior subcapsular cataract, and you can see the fundus picture showing those depigmented areas, and also in the left eye. So these days, after this high quality spectral domain OCT and swept source OCTs have come, many times we are not doing more imaging to diagnose VKH. Sometimes pictures are so characteristic on B scans, B scan OCTs that you don't even need. But in this case, probably he was on steroids off and on, so you don't see much of disturbance in choroid. But if you look carefully on this vertical OCT scan, you will see some elevation here, which is corresponding to this point, which might suggest you that there is some inflammation going on. But we went ahead and did ICG, and then these are the indications for ICG when you don't have a clear-cut diagnosis of VKH. The difference it makes is that once it is a VKH, like a colleague was asking about sympathetic also, many of them will need immunosuppression for really long time. So, and now these days it's very tricky. Now parents also have read everything about VKH, and they'll also ask categorically that is it a VKH or not, because it carries some kind of impact on whole family. So we did ICG, confirmed VKH, and you can see on angiograms disc also leaking, which again goes in favor of VKH. He was put on systemic immunosuppression. Normally we are doing this TPMT test, and slowly we escalate the dose. Initially we control it with oral steroids and then add up azathioprine, and patient has been reasonably stable for 1 year, and then he comes back with haziness and distorted vision. So all of you know that VKH patients are prone to this juxtapapillary macular neovascularization, and you can see this fluffy hyperreflectivity in subretinal area, and many of them are type 2 MNVs. You can see SRF vision has dropped to 624, and if you see on more magnified picture, and you have to scan this area very carefully when you are rolling out juxtapapillary MNV. Angiography also shows, I think maybe younger colleagues have not seen, but this used to be lacy hyperfluorescence surrounded by hypo, a very characteristic of classic CNVM, which we used to call it. So I thought most of them are type 2. Let me get away with this, with the probably most potent anti-VEGF. So that's why we gave, and patient was on immunosuppression, so we thought let's just give brolucizumab, and you can see the response on the right side. This is 3 weeks after injection, and you can see the membrane drying up, fluid gone, visual acuity has also improved, and this patient maintained dry retina for almost 12 weeks after injection, and but then at 16 weeks after injection comes back with recurrent subretinal fluid, and again fluffiness coming back, membrane regrowing. Now because I have given one injection, it is an inflammatory disease, I was little hesitant to repeat brolucizumab, and so we went for faricimab, and again you see the response is reasonably okay 4 weeks after faricimab injection. Can you just allow me one more minute? I'll quickly, okay. Yeah. So at 7 weeks, and then I think at 13 weeks, you can see again SRF coming back. And but again, I thought 12 weeks is fine with me and patient also. Let's go for faricimab also. We gave this, and 2 weeks after faricimab, he comes with sudden drop in vision, and there was significant subretinal heme. Morning we were having discussion: when should we intervene, when should we observe a patient with subretinal heme. So I think one of the criteria in our practice is we try to see the height of heme at the fovea itself. Uh, One is the extent of hemorrhage, but fovea is the most important reason we are concerned with. And many times, even if you observe, they might get absorbed, and visual acuity might improve to 20/20 or 20/80. But you see on autofluorescence, you check their macular function; it is not as good as you used to be, and that is the reason we decided that we will displace this with gas, and pneumatic displacement was done, and you can see within 9 days of pneumatic hemorrhage going down, visual acuity improving to 618. And in fact, you can always find where that blood has shifted. Almost always it will go down and temporally. And then by then I probably realized that I should stick to the stronger drug, and I have repeated brolucizumab. But this time what I did was I added oral steroids also for good 8 weeks, just as a top up of immunosuppression. And now so far this patient has been maintaining well 30 weeks from this second brolucizumab injection, and stable membrane not coming back. So I think I like to conclude that as we all know, rule out juxtapapillary MNV in VKH, treat them aggressively, keep looking at the border of CNVMs for SRF, because they don't directly involve fovea. Sometimes vision may not be the best guide. And if there is significant subfoveal heme from hemorrhage, consider pneumatic displacement. And we have used brolucizumab in so many now inflammatory and idiopathic MNVs. So I would recommend, if you have access, I think you can use it. Thank you. Yeah, it is immediately prone position, and I try to inject isoexpensyl gas instead of pure gas. So what I do is I take 0.2 ml of C3F8, and I will almost always go for a longer acting gas, because we have shown in other meetings also that this displacement happens in multiple steps also. So if you have significant hemorrhage, you continue the prone positioning till your fovea is free of blood. And why I go for isoexpensyl gas is I take 0.2 ml of C3F8 and mix it with air, make it 0.7, 0.8, and so that I get a very large bubble on table, because compliance of patient is very good as long as they are in hospital. So we make them prone in hospital itself for 3-4 hours, and then we ask them to do same for next 48 hours. Then we see them and then titrate based on shifting.
Pneumatic displacement is always under considered in such cases, but I think it plays a very important role, and you do not need to go for surgery and TPA. You can try the pneumatic displacement, especially with young age. I think this would be enough. Usually I'm using SF6 and pure gas, and in my hand it is enough, but also C3F8 will give you longer duration of the gas, and maybe will help to displace it even for a longer period, which is good enough. And I thank you for the consideration of the secondary neovascular membrane. In such cases, it is very common. So we need always to be alerted about it and treat it promptly when it happens. Thanks a lot.
Yeah, thank you, Dr. Singh, for this peripapillary type of choroidal neovascular. It's not the same as that we saw in the age-related macular degeneration, and this is mostly related to chronic inflammations. A patient who is really having good control of inflammation, usually they will not tend to have this, except the case getting to the stage of chronic and missed the window of is the therapeutic window treatment. Usually they are responding very well to anti-VEGF when they given, in addition to control of the inflammation. If the blood there, reaching the fovea for a couple of days, we will not say that it is toxic as that we have with, subretinal hemorrhages usually. Anti-VEGF could do the job. If not, then, displacement is essential in these cases. We don't like to somebody, in addition to what you have, you will let him to have more, scotoma at the fovea. So it's a great to have such case like that. We'll move to the next speakers. Unfortunately, Dr. Fahad. Yes, go ahead. Usually, we have to attend before 2 weeks from the beginning of the organization. So 2 weeks usually, because the blood is toxic, the iron is toxic to the photoreceptors. So up to the research, as far as I know, it should be